Good morning, everybody. It's lovely to see people in the chairs at 8 a.m. on Sunday. Thanks for coming up to join us. The anesthesia crowd's the only people you can expect to think 8 a.m. means sleeping in. So here we are, ready to go. Today, I have the pleasure of moderating a panel to discuss anesthesia in the dental office, gaps in safety and resources for improving care. To start us off this morning, we have Dr. Cara Barnett. Cara Barnett is an associate attending and director of anesthesia services at the Memorial Sloan Kettering Monmouth, and she serves as a director on the board of directors for the Society of Ambulatory Anesthesia, or SAMBA. With that, Cara, come get us rolling.
Hi, good morning, everyone. Thanks for coming, and thank you, Dr. Valek, for having me. You might be wondering why an ambulatory anesthesiologist at a cancer hospital is going to be talking to you about this. So I'm going to kind of go through my story and then go through a paper that we published with a bunch of our SAMBA colleagues. So basically, I have no disclosures. I'm just going to be going over the one provider model. That means when the person who's giving you anesthesia is also the person that is sedating you. So my interest started, thank you, Facebook, for being basically my depot of all the current news. When Dr. Henry Patel, a 53-year-old cardiologist, passed away a couple of years ago, he was a healthy guy, father of 2 kids. His patients loved him. Luckily, through, it's a small world after all. It turns out my good friends from internship lived down the street from her and were friends with his wife, Sheetal. So I got in touch with Sheetal. She shared some of the slides you'll see here about how he passed away during his dental implant during monitored sedation. So he was a healthy guy, as you can see. You don't see sleep apnea listed. He was he wasn't obese, etc. He actually first went in for monitored sedation for dental extraction with his friend, an oral surgeon, did fine, and then he went back in for the implant and unfortunately passed away. This is a copy of the sedation record here. I just kind of boxed around where you see what anesthesia he received, and from talking to Sheetal and talking to his colleague, Dr. Rob Harper, and just from what I could see, the best picture I could put together is that he may have had laryngospasm leading to apnea and hypoxia. They tried to intubate him. It was esophageal intubation, unfortunately. They didn't start CPR until EMS arrived. Unfortunately, he then had delayed CPR. He did have return of circulation. Unfortunately, 4 days later, they removed care, and he passed away, and this is a copy and paste of what was in the actual autopsy report. So since then, she's been very much a proponent of safety in dental offices, making sure that everyone gets safe care, and I was privileged to hear her speak at the SAMBA meeting in May this year, Society for Ambulatory Anesthesia, and also on the other side is Dr. Rita Argawal, who's also very active in it. So I'm just going to be going over some of the data from our paper that we put out. It was a huge effort by many people because we looked up all 50 states' rules and regulations the best we could. Hopefully my QR code works. Obviously, laws may have been changed. You know how it goes with papers. You get the data, you submit it, they review it, so even though it was published earlier this year, I'm guessing not a lot has changed, but this is based on the data that we had at the time that we put it together. And we were also privileged to also have a little feature in Anesthesiology News. So here we go. So we're going to start with the definitions of sedation in general. So here we all know and love these. These are the ASA definitions. When we looked up what we could find for the different states, we found there's a lot of inconsistency. Not every state used 4 categories. Many of them just skipped even mentioning what minimal sedation is for them. What I found was I looked, for key parts of where states they fully align with ASA definitions. It looks like only 4 did. A lot of them talk about protective reflexes when you look at their definitions. So just for fun, I included 2 here, Pennsylvania's definition of general anesthesia versus the ASA. And I tried to, highlight things that were the same, or at least, pretty much the same. And then you see that the purple and the gray are not exactly lining up. So there were several states like this where, it was similar, but not always exactly the same. If we look at patient selection, there's a lot of variability. Some states do mention, for example, that ASA 3s are not candidates outside a hospital setting for moderate sedation. Some say don't do ASA 4s and 5s, but again, not a lot of consistency. The evaluations, what they require in them, there was limited data for that. Just to include one of our tables here, you can see some states don't even require a medical history or a physical exam. And I know I just can't imagine doing anesthesia without, talking to someone and getting their full medical history. And then when we look to see how many states require fasting, we found only 8 states included that. In terms of resuscitation emergency preparedness, I think this is all a very important part of our practice because as we know, 98% boredom, 2% sheer terror. So you always want to be ready for our sheer terror. We found that 13 states required emergency simulations and 10 mandated, repeated at just different intervals of time. And in terms of emergency preparedness, this, again, tables from our paper where you could see the most number of states that we could find that required anything was 15. Hypoxia, only 1 state specifically mentioned that. And local anesthetic overdose, or what we would probably call LAST, we found 1 state that required a preparedness for that. If you look at those that require emergency drugs specifically, like, antagonists for your benzos and pressors, and et cetera, only 15 states, and no states required a lipid emulsion. And we know in general, obviously, dentistry uses a lot of local anesthetic, but none required that. If you look at drugs for sedation and anesthesia, some states had absolutely no restrictions. 3 prohibited thiopenthol. Anyone know the last time it was manufactured in the U.S.? 2011, guys. So, to me, it was a little surprising that nothing, these 3 states have not still updated things, being that it hasn't been updated since 2000, at least before 2011. A lot of states did mention this maximum recommended dose. So this was a table from our chart just showing, how different states define sometimes the type of anesthesia you're doing just by this, what we call MRD. And sometimes it's based on your ASA score or adult versus child, et cetera. But a lot of variability, say, between Iowa and North Dakota. And here you see, New Mexico, where they talk about enteral versus parenteral moderate sedation. That I found also kind of interesting, too, how they distinguished between the two. So let's talk about monitoring. So if your proceduralist is, busy inside your mouth, who's the one that's looking at the monitor? So usually that's a dental assistant, not a hygienist. And so the level of schooling for, say, a dental assistant is different in terms of a training requirement. Usually a dental hygienist has to go to 2 or 4 years of a post high school program, and your dental assistant may just have a high school diploma. So requirements by state, again, vary. This is an example from our chart and how we found some states didn't have any specific requirements, whereas some states required 1 or 2 people. I think the most we saw was 3 people, but a lot of variability. And so in terms of pulse ox, I just wanted to compare what the ASA says versus what we could find. And 36 states we could find required it versus capnography, 27 states versus the ASA. And, sometimes it was a little confusing because some states would require, capnography if you were intubated, but not if you, got minimal or moderate sedation. So if we look at emergency and airway equipment requirements, we found 23 states specified, and some just did not specify the airway equipment, but did address some of the equipment, or 9 states. And one thing that we found a little tough in terms of researching is sometimes we didn't find like a section, it was like equipment or this or that. Sometimes we had to go into look for the application for permit to find the requirements. So in some areas, for the equipment specifically, we had to look in other places to find what the requirements were. Some states refer to the dental societal recommendations, and some states did not mention that there were any requirements at all. And then we found that 8 states didn't even mention capnography. So we look at procedural selection. We didn't find that any states required procedures based on anesthesia type. We did find that Oregon did limit the type of the procedure. Like, for example, you can't do a rhinoplasty or blepharoplasty, more, I guess, cosmetic type of procedures. But, we thought it was pretty interesting that there were no requirements or restrictions. So education and training is obviously very important. This is from the American Dental Association. Where we found a lot of variability was with moderate sedation. I try to put a box around what their requirements are. So it's usually 60 hours of instruction, and then you have to manage 20 patients yourself, and then you have to show that you're competent in placing airway and rescuing patients from deeper than intended anesthesia, and being able to place vascular access and things like that. So what did the states say? So we found that 37 states conformed with the ADA, and 1 state, good job Illinois, requires more hours than specified by the ADA. We found that 24 states specify there should be training in airway maintenance and complications. And then if you also look at continuing education, like what we consider CME, specific to practitioners who are doing anesthesia or sedation, we found that 44 states have that. So, I can't say every state may require like CME for being a dentist, but if you look at those that, were dentists or practitioners are also doing sedation or anesthesia, we found 44 states that mentioned a requirement. So this kind of goes hand in hand with permit requirements. There's a lot of variability. Most states did not require a permit for minimal sedation, and some states never even defined minimal sedation at all. So it's hard to require a permit if you never defined it. 43 states require a permit for moderate sedation, and then all states require it for deep sedation or general. And a lot of the deep sedation and general a lot of times kind of go hand in hand when you look at the laws and the permits. And then pediatrics was a bit confusing. We found that there were 10 states that require it, but the age requirements very much vary. Like some states, you'd be considered pediatric if you were under 12 or 13, some under 18. So a little bit confusing with that. And I just kind of pulled out Kentucky because I could fit it on my slide here, what they have in terms of what we can find. And CODA is the Commission on Dental Accreditation. So here, example of just, a not very descriptive requirements for permit for one of the states. So if we look at our BLS and PALS and ACLS and such, BLS is required by all 50 states, but we did see variability in terms of ACLS requirements. Only 12 for minimal sedation, 49 for moderate, and 50 for that deep sedation or general category versus auxiliary personnel. So, you might be practicing, obviously not at a medical center, and the auxiliary personnel are the only people that are there to help you. So the requirements are, only, for example, 3 states require it for deep sedation or general. Most states at least require BLS for moderate sedation or more. And here's just an example that we found with Alabama. And if we look at PALS, that was very complicated. I'm not going to really get into that. But again, the ages vary. And for minimal or moderate sedation, for example, they may require PALS, but then that same state may not require for deep sedation. So it was a little interesting how sometimes it was required for the lower level of anesthesia, but not the higher level. And then PALS was required for what we call, when I say all 3 levels, I mean basically minimal, moderate, deep, general. 38 states did require that. So if we look at state reporting of events, 27 states require, what I think would be most of what you would think of: death, hospitalization, other important events. But there were 10 states that did not require any reporting that we could find, and there was nothing that we could find about having to report near-miss events. And the timing varied. For example, was it 24 hours, 48 hours, 72 hours, et cetera. And I think that's why it was very important to Sheetal to make sure that in the autopsy report that they included that it was death specifically to anesthesia during the procedure, because they withdrew care 4 days later, and so some states may not even consider that just because the death happened later on. In terms of on-site inspection requirements, 37 states require it. Only 18 require re-inspection. Usually it's performed by the dental board, and sometimes there are exemptions allowed. All right. So I went through a lot of data for 8 o'clock on a Sunday after probably people went to 3 or 4 parties yesterday. So just to kind of reiterate some of the challenges that we had, it was very difficult to find a lot of the data because, like I said, sometimes you would have to go into the permit section to find some of the data, or, a different part of the rules and regs of that state to find the information that we were looking for. So we did our very, very best, and we did it. I have one of my med students in here who was fantastic, was also part of the study. We could all tell you it was a really hard task to get all the data. So just a bit of a summary of what we found. Just a lot of variability in the laws and difficulty finding the information that we were looking for. Just diverse requirements across all fronts, whether from ACLS requirements to monitoring, emergency equipment, et cetera. So we felt like after we went through this paper that our best course of action would be standardization of the rules and regulations, and just having also a nationwide adverse event reporting system just to see, how we are doing in the U.S. in terms of safety. Because, I'm sure a lot of us on Facebook and the news, you hear about events, but is that, not everyone runs to the media when something happens. So how safe are we doing, and what can we do to make it safer for our patients? And I think for us, it's just advocating that you're getting the best care you can get, whether it's, at a dentist's office, out in the community versus a hospital versus an ASC, et cetera. So I just, for this slide, I was thinking I'll put some pictures up of people who passed away during dental sedation. And what I kept finding is I kept finding pictures. And so I put a bunch up here. And just to end it with, this safety is not an option. It's a fundamental right of every patient. And just a little plug for Society for Ambulatory Anesthesia. It's a great meeting, and we hope you can join. And that's it for me.
Perfect. Well, thank you so much, Dr. Barnett, for kind of setting the stage of what's going on out there now. And there we go. There's obviously a lot of insights were shared there about the many gaps that do exist in the laws and regulations regarding patient care during anesthesia and sedation in the dental office. I'm Dr. Megan Valek, and I'm the anesthesiologist in chief for Ambulatory Anesthesia Care Midwest, where I've done all ambulatory and mostly office-based anesthesia for the last 12 years. I'm on the SAMBA Board of Directors. I chair their office-based anesthesia committee, and I also serve as the vice chair for the ASA's Committee on Ambulatory Surgical Care. So this is a picture of one of our dental office sites. As you can see, there is a lot going on in this picture. Significant amounts of equipment and monitors all squeezed into the small space. It used to be a rare sight, anesthesia in the dental office. But an article by Dr. Mark Saxon et al. In 2019 estimated that annually 2.8 million deep sedation and general anesthetics are given in office for oral surgery. Conservative estimates say that has grown 5% annually and will continue to do so for the foreseeable future. In addition to that, upwards of 200,000 sedation cases happen annually in the U.S. for pediatric dentistry. The numbers are there, and we've all heard the media cases of deaths in the dental office. With the lack of national legal guidance, it can seem confusing and daunting trying to tackle this issue. And if you're thinking about moving into the world of office-based anesthesia, you're probably wondering where to look. The good news is that with the increased volume and attention, there have been some terrific articles of late about how to get to safety and standardization in the dental office, and multiple groups are continuing to work on it. In the meantime, I'm going to direct you to some tools that already are at our disposal in the form of new and revised statements from the Anesthesia Patient Safety Foundation and the American Society of Anesthesiologists. So I want to start out talking about the Anesthesia Patient Safety Foundation consensus recommendations for safe conduct of non-operating room anesthesia. This came out as a meeting report from their 2022 Stolting Conference of the Anesthesia Patient Safety Foundation, and it was published in the fall of 2023 in the APSF newsletter. So why am I talking about non-operating room NORA recommendations in a talk about office-based anesthesia, or OBA? In 2022, when the APSF convened its annual Stolting Conference with the focus on safe conduct of NORA, they decided to tackle this issue. I want to put in a little plug here that the Stolting Conference is really cool. It's a working conference, unlike any other that I've ever attended, that gathers experts from all across healthcare. There's clinicians, industry folks from pharma, accreditation, and technology. They put them all in one space, and they tackle a topic that's relevant to patient safety. And by the end of it, they've set a framework for a consensus statement that is then refined and published. If you ever have the opportunity to attend a Stolting conference on a topic that you're passionate about, please do so and contribute. So now, I hope that this group knows better than most that NORA does not equal OBA. But after much discussion at the conference and much dissent, probably most loudly by me, APSF nonetheless felt they needed to include OBA under the umbrella of NORA, because given the media attention and the public concern over anesthetic care, particularly in dental offices, they felt obligated to speak up on the issue. Interestingly, they went one step further and said these recommendations should apply even to sites where sedation is performed with no anesthesiologist present. Because of the inclusion of OBA, the recommendations needed to be more generalized and looser than they would have been had they focused solely on NORA in the hospital environment. But nonetheless, they set a nice framework for safety in NORA and OBA locations, with particular insight to unfamiliarity to location and personnel, and the importance of teamwork, team planning, team training, and facility considerations. They outlined the basic equipment and monitoring expectations and put a lot of emphasis on considerate planning of the physical facility and the workflow in these places. Next up, I'm going to move to revised ASA statements in this realm. So in 2023, the Committee on Ambulatory Surgical Care updated their statement on office-based anesthesia. And in that year, I had the pleasure of being nominated to the role of Vice Chair of the ASA Committee on Ambulatory Surgical Care at the suggestion of Dr. Valadon, the previous chair, and 5 minutes into the meeting, I quickly realized why. Because we were tasked with doing the much-needed updates to the ASA statement on office-based anesthesia, the statement on qualifications of anesthesia providers in the office-based setting, and the statement on the safe use of propofol. The one that we revamped most significantly was the statement on office-based anesthesia. Prior statements referred back to the essentials of OBA. It basically said what we should do is the ASA basic standards for care, and then you should have a plan for emergency transfer and some oxygen source and a flashlight. This was not helpful when I was going in my OBA practice, just getting started in this realm and really looking for some solid guidance. So taking liberally from the APSF statement, as well as the 2023 updated ASA NORA statement, while now accounting for the significant differences in NORA and OBA, We put together the new OBA statement to provide a useful scaffold for the many unique needs of office-based anesthesia that are generally handled for you in the hospital and ASC setting. Of note, you need to be not only proficient in anesthetic care, but also cognizant of the appropriate procedure selection, making sure that the surgeon or provider or dentist is actually qualified to perform the procedures they're proposing under anesthesia. It also addressed the need for you to assess your state and local laws, look for regulations and policies regarding to office sedation and anesthesia. Additionally, it mentions the facility concerns like availability of electricity in your workspace, fire exits, and fire escape routes. Important equipment and monitoring needs are also taken into account, so defibrillators, monitors, including end-tidal carbon dioxide monitoring, suction, emergency airway equipment, ACLS training and medications, the ability to provide positive pressure ventilation, and of course, still oxygen and flashlights. It's not comprehensive, but that means it's also not overly prescriptive, and it does allow for the clinical judgment specific to your setting by the anesthesiologist in charge. Next up, we did revamp the statement on qualifications of anesthesia providers in the office-based setting. There weren't a lot of changes to this, but it still highlights the understanding that although ASA feels an anesthesiologist should be present for all anesthetics, we recognize there are states that allow other models, and as such, we want to still hold them all accountable for a supervising physician that is capable to provide sedation, anesthesia, and rescue techniques relevant to the type of sedation and the procedures that are being done in that office space. This statement also makes a point to highlight the particular need for anesthesia training by those physicians, even if they are not anesthesiologists, given that in the office setting there is no institutional backup and there are scarce emergency resources compared to hospital or ASC settings. Additionally, we revamped the statement on the safe use of propofol. I want to note that this statement is not unique to office-based settings. It applies to the safe use of propofol across all locations and specialties, but is particularly relevant to the office-based anesthesia setting where total intravenous anesthetics with propofol is often the preferred anesthetic for ease of use. It's non-MH triggering. It allows for rapid titration and antiemetic effects, which are all in line with the needs of an office-based scenario and patients going home soon after. There were few significant changes to the statement, but I do want to highlight that the statement does include the FDA insert language that after much discussion by our group, the ASA strongly supports that anyone administering propofol should be trained in the administration of general anesthesia and not involved in the conduct of the surgical or diagnostic procedure. This is my reference slides. Again, it feeds back to all these statements. The QR codes on each of those pages should lead you directly to the updated statements as well. And then, of course, I'm much like Kara, going to put in my pitch for Sandbach. Come if this interests you, if you're all about ambulatory, if you're getting rolling in the office space or you've been there and you want to find a way to increase your standardization and patient safety in this realm, it's a wonderful meeting with a lot of people interested in these topics. Thank you. I now would like to introduce to you Dr. Stephen Geyer. I'm going to squint at my phone here. Dr. Geyer is at the Miami School of Medicine. He is the past chair of the ASA Committee on Ambulatory Surgical Care. He serves as the AMS representative to the American Association of Oral and Maxillofacial Surgeons. Additionally, he serves on ASA's Committee on Quality Management and Departmental Administration as the liaison for the American Association for Accreditation of Ambulatory Surgical Facilities, Quad ASF, and the Accreditation Association for Ambulatory Healthcare, AAAHC.
Thank you. Hello. Flashlights and oxygen. Okay, that's my takeaway for today. Flashlights and oxygen. Thank you. I'm Steve Geyer, and I'm from the University of Miami. I am the medical director of surgery for Bascom Palmer Eye Institute, its hospital, and its various ambulatory centers throughout the state, and soon to be internationally as we're opening up a facility overseas as well. And you may ask, why is an eye anesthesiologist speaking to you about oral surgery and anesthesia for oral surgery? Well, in our eye hospital, as you can imagine, we see a lot of pediatric patients. We do about 5,000 pediatric patients a year, many of them healthy, many of them syndromic, with multiple issues besides just the eye. So we are the home base for the University of Miami's oral maxillofacial surgery residency experience in pediatric anesthesia. We have other locations as well, but the vast majority of their experience occurs with us. So I've been involved with oral surgeons for a good proportion of my career. So Dr. Barnett started by setting the stage about patient safety gaps in terms of state regulations, how things are not consistent throughout. And then Megan spoke about ASA and APSF statements and such. And I'm going to take it in a different direction. I'm going to be talking about accreditation and talk about how accreditation can provide structure, whether it's for the anesthesiologist that comes to the oral surgeon or dentist's office to provide service and care to patients, or it's a setting that does not have an anesthesiologist present. There are things that are mandated by accreditation that provide that structure to add a modicum of safety that goes beyond state regulations and such. As we saw, the state regulations are often quite lax. So in terms of accrediting organizations, we're all familiar with the Joint Commission and also DNV Healthcare, right? As residents, that's what we get exposed to in our hospital-based residency programs. But the Joint Commission offers accrediting services for office-based surgery. At the University of Miami, we have 4 office-based oral surgery clinics that do procedures, and they're all accredited by the Joint Commission. And that makes sense, right, from a logical perspective. As a large organization, you don't want to contract with multiple entities, right? So that, by and large, at most university hospitals, university-related systems, that's the case of what you find. This is a mouthful. The Accreditation Association of Ambulatory Healthcare, easier, the AAAHC, started out exclusively for ambulatory surgery settings, and then they expanded into the office-based arena, so they provide services there as well. And this is really going to be a tongue twister. The American Association for Accreditation of Ambulatory Surgery Facilities, that no one has ever said that whole thing before. The Quad ASF, and thank God now they've rebranded, they're now the Quad A, right? They started out as an entity from the plastic surgeons. The plastic surgeons started their organization to serve their needs, and from that expanded quite broadly. They actually offer specific tailored accreditation for the oral surgeon's office, and a separate accreditation for the oral surgeon's office that does pediatric procedures. So I want to touch briefly on the Commission on Dental Accreditation, CODA. That's American Dental Association's CODA. They accredit educational programs. So our interaction with them at the university level, is they come in and they look at the education and the setups in the oral surgeon offices that we have responsibility for. So that's sort of separate and distinct from what we're talking about today. Now, as we saw from Kara's talk, the state regulations are all over the place. You can get so-called deemed status for Medicare from just state-specific oversight, but and that's in a number of states, as she pointed out. But if you have an accrediting agency come by, that's a standard much higher. So accreditation is voluntary, and you're not supposed to do air quotes, but I'm going to do it. Voluntary, okay? But it's really not. whether or not it's required by law in different states, it really it's not voluntary. A number of states, as Kara pointed out earlier, there are triggers. So if you're going to do deep sedation or general anesthesia in the office, that mandates that you have an accrediting body overlook the office milieu. But it's really not mandatory, particularly because when we get down to the second most important thing we do, the first most important being, of course, patient safety, and I'm saying this completely tongue-in-cheek, getting paid, right? Insurance payers will mandate it, right? If not, the oral surgeon may face payment denials, or they may be excluded from insurance networks. So insurance participation is really a big prominent motivating factor to have the office accredited. Malpractice insurance premiums could be affected, right? And there could be coverage limitations imposed upon that practicing oral surgeon. Of course, there's legal liability. There's the strict legal, and then there's the non-structural legal issues that may be a potential indicator of a substandard practice. It can be alleged if you don't have accreditation in your office. And then there's marketing reasons, right? Professional reputation to have accredited. So there are a number of domains that are covered, and they're too extensive to go in completely. So we'll just touch on a few of them. But the main point is that with accreditation, you get the mandated internal policy development. You get the mandating of protocol development and reporting systems, right? So each body, whether it's the AAAHC, the Quad A, the Joint Commission, has their own detailed requirements, and they do vary sufficiently. But the core standards for anesthesia safety, they're broadly consistent throughout. So the first one, and I think probably for me, the number one on the list would be emergency preparedness, right? Safety plans have to be put in place, and they have to be written. So the time has to be taken to actually delineate what occurs in the case of an emergency, right? And also mock drills are mandated as well. The staff have to be drilled. Everyone needs to know what their roles are. And of course, the proper equipment and medication must be available, right? So you have to be able to handle critical airway issues, cardiac arrest, anaphylaxis, MH. These are all major anesthesia concerns. So accrediting provides the structural support in some sense to make sure that things are occurring that need to be in place, that are there. But also you have to have the fire plan, the emergency power protocols, evacuation protocols, and importantly, a transfer of care plan. The facility standards must be up to snuff. They require that you not only have the proper airway equipment and delivery systems for what the office does, but you also have to have age-appropriate and size-appropriate equipment as well. And most importantly, credentialing. Personnel have to have the qualifications and training. Now, as we pointed out by our two previous speakers pointed out, the rigidity of the standards are very loose, lax, but they're in place. And I think that as a society, we continue to strive in the right direction towards this. So in the office setting, if sedation or general anesthesia is around, there has to be the stipulated education, and current certification has to be there. In terms of airway management and cardiopulmonary resuscitation emergencies, we're all familiar with ACLS and PALS. Those are stipulated. But now there's been a little bit of a change as the various subspecialties are now offering their own tailored emergency management courses. So for the oral surgeons, they have something called the O-BEAM course, which is the Office-Based Emergency Airway Management course, which I've had the privilege of attending a few of these sessions already, in which they review proper techniques and varied techniques for handling an airway. For us, in anesthesiology, we have our PEARLS course, the Perioperative Emergency Resuscitation and Life Support course. So these things are mandated by the accreditation bodies. Now, a key difference between AAAHC and Quad A is that the Quad A will take into credit, the fact that a lot of the hands-on materials that are required in these courses are routine for anesthesiologists, right? So the Quad A will accept documented experience in terms of case logs, in terms of simulation sessions done with staff, et cetera. The AAAHC is still saying that you have to have a hands-on component to your cardiopulmonary resuscitation recertification classes. So for them, PEARLS is not an acceptable option because there is no hands-on component of that. But ASA is working with AAAHC. We recently got them to debrand the stipulation. So instead of saying that you have to have ACLS and training, they now say you have to have training in this area. But in other parts of their standards, they do still talk about the hands-on component. So it's a little problematic for anesthesiologists, but we're working on it. Most importantly, you have to have ongoing reviews of adverse events, complications, near misses, morbidity, and mortality, and you have to show participation in quality improvement activities and have a risk management plan. All important points. And I would be remiss if I didn't talk about infection control, because it was anesthesiologists and an anesthesia issue that actually brought this to attention nationwide. Back in 2008 in Las Vegas, there was an endoscopy center that was reusing propofol syringes or continuously using the same syringes on patients. And there was an hepatitis outbreak, and there were 9 patients that had hepatitis C. And they actually had to reach out and contact over 50,000 patients to tell them that they had potential exposure. And since that point, this has really been a primary focus for all accrediting bodies to look at infection control. Certifying bodies also seek to have patient care standards, right? So it was pointed out that a lot of states, there is no requirement to have a pre-op evaluation. Well, for the accrediting bodies, there are. You have to have an appropriate pre-op anesthesia evaluation, including the medical history, the physical exam, et cetera. And there has to be a determination that the patient is actually appropriate for the setting, right? Informed consent is reviewed as well, and that there are recovery room and discharge criteria. Again, AAAHC and Quad A differ in these regards. For AAAHC, if you're an anesthesiologist, you have to be present until the patient is discharged from the facility. So my final slide, there's increased scrutiny of office-based surgical practices, especially when moderate and deep sedation and general anesthesia are employed. Safe training in terms of cardiopulmonary emergencies is stressed and routinely audited. There's a focus on ensuring that there's age and size appropriate equipment for the patient population served. Recently, the terms of morbidly obese patients that we're all seeing more and more of, that your facility has the ability to take care of these patients safely. And it's not just for the safety of the patient, it's also for the safety of the staff as well, right? There have been updated requirements for continuous capnography, for example. It was pointed out that it's not required in a lot of state regulations, but it is required by the accrediting bodies. And there are updated standards related to machinery and equipment. If you're an anesthesiologist that brings your own anesthesia equipment to the oral surgeon's office, you're now required to have that equipment present when there's a site survey, and that the records for your equipment need to be copies need to be maintained in the office itself for ready access at any point. And that's my presentation. I promised not to do this, but I'm going to do it anyhow. There's the Samba slide. Thank you very much.
Wonderful. Thank you guys so much. That's it for our talk. So we have some time for questions. Please, if you have a question, step up to the microphone or speak loudly, and we'll repeat it up here. We're happy to take questions.
More of a statement that maybe you can comment on a couple of things. First, I just want to identify myself. I'm Lenny Naftalin, immediate past president of the American Society of Dentist Anesthesiologists. So there's a couple of things that I think are left off of the discussion here, and one in particular is that, well, I want to actually kind of give a landscape of how things work in dentistry, and it's just like the ACA, it's really complicated, right? And if it was really simple, it would have been solved already. So every state licensed dentists, and they license them for different things. So where we have sort of, discordant kind of laws is because it's all done at the state level. And the American Society of Dentist Anesthesiologists has recognized, and we've tried to put together, along with the American Association of Oral Maxillofacial Surgeons, a model legislative document that we can give to all states to try and solve some of that. One of the big things that we have recognized is that there's almost no regulation or oversight for CRNAs or physician anesthesiologists coming into dental offices because the state boards can't regulate them, and most of the medical boards don't want to regulate them because they're not in medical facilities, they're in dental facilities, which means that there have been, I know of one, again, I don't like to point fingers and throw shit at people, but I do know of in Arizona, there's one CRNA that's had 2 deaths, and in both of them, the nursing board said everything he did was great. So I think that we have to recognize that that is a huge sort of blind spot, and I would love for ASA and SAMBA to help us kind of close that gap in how things are done and recognize that that is a big piece, and that's one of the things that our model legislation dealt with. The other thing I just want to just make sure that it's understood that because it's at state levels, it's also very political. And so once we get to political, it gets really hard, and we have to sort of take into account personalities and people and stuff like that. And then the last thing I think I want to just make a comment on is what we've, and me personally, have really tried to do, because I think we sort of maybe understand a little bit of what the problem is, at least from the numerator standpoint. We have some reports of some bad outcomes in dentistry, and maybe we can make some cases on it, but I'm not sure we really know what the denominator is. And so are we talking about 10 deaths out of 10 million or 10 deaths out of 1 million? And those are huge different things. And what we really need to figure out, and Megan, you and I have talked about this, is a real reporting system where we have something that we're mandated for everybody to report, which would include dentist anesthesiologists, physician anesthesiologists, CRNAs, oral surgeons, pediatric dentists, general, everybody would be somehow mandated to report so that we actually have a real idea of what the problem is. Because that's what I think we're sometimes like, swinging at the piñata blindly and not really sure what we're getting. And then one last comment that I just want to say about maybe in terms of the statement on propofol, that maybe that's all going to be fixed in the next couple of years as I think more people start using remimazolam, and that may be the fix to that one. That's a lot that I just said. I'm sorry for taking up so much time, and I know it's mostly statements, but you can make comments on what I said.
I use remimazolam in my facility. Not a lot of places do. It is a great drug. And for those of you who don't know what it is, it's an ultra short-acting benzodiazepine that has less cardiac and respiratory depression. And I know for my personal use, especially with ASA4s, we do a lot of outpatient interventional radiology. Instead of getting that huge drop that you sometimes see with propofol, you kind of have like this nice train track. So it is a great drug, but it's about twice the price as any other. Yeah.
In terms of safety,
exactly. Exactly. So it's FDA approved for procedures 30 minutes or less. I mean, obviously, if you go over a 30-minute mark, it's not like you turn into a pumpkin, but that's what it's FDA approved for. It's also FDA approved. I know they're working on it with pediatric, but I know for adults, it's FDA approved as bolus doses. We use it off-label as usually as an infusion when we use it, which is, I think we all like infusions better. But I will say it is a great drug if you can get your facility to pay for it. And then I'll hand this over to you, Megan, for whatever you want.
Oh, sure. Thanks so much, Dr. Naftalin, for sharing. And I know you and I have had this discussion a lot of times. Absolutely, we are missing the denominator here. And I think in office-based anesthesia in general, it's really hard to benchmark what you're doing. Are you doing the right things? And I hope. Obviously, I really glossed over what are in those statements. A lot of time and work went into putting those together. If you're doing this, please look at those. Please make sure that you're meeting those statements and recommendations. Again, they're not overly prescriptive. They are a framework, and you can apply it to your scenario as you see. But I think getting a database, getting an outcomes registry that's really specific to what's happening in the office is super important, and we're working on it. I think we're finally going to tip the scales and make this happen. It's going to be really hard to mandate everybody report to it, but I'm hoping that most people that do this, and given the social and media presence around this, are going to want to show that they're doing the best they can and making it in the, and there's going to be a little bit of the shame factor of people who don't want to put it in there. Well, why don't you want to submit? What are you doing so wrong in your place? So just getting that data, I think, is going to be really important, and you're absolutely right, and we need to all work together on that.
So a few comments. One, Remy Maslam, we ran a study at my Miami facility, and so we were able to use it hospital non-formulary for about 2-3 years. When the study stopped, the hospital said it's too expensive, and they took it away. So we're looking forward to having it back. Very interestingly, in places like Japan and a few other countries, it's approved for general anesthesia only. In the United States, it's for sedation only, but of course we all do everything off-label anyway, so we'll do what we want, provided we have access. It's, again, proves the rule that, we're all, money rules everything, and so that's a bit of a hindrance to its adoption at this point. I'd be remiss if I did not address your first statement about CRNA issues. I would be remiss if I did not express gratitude to AMIS, to the American Association of Oral and Maxillofacial Surgeons, for their white paper that came out less than a year ago, in which they affirmed that nurse anesthetists need supervision, and they need supervision by people who are trained in providing anesthetics and anesthesia on a professional level. So, thank you.
Amen to that last comment. Jeff Ploganoff, past president of the ASA, and but more importantly than that, I'm working in this space now full time. Have for about 5.5 years. My wife 6.5 years, and I'm turning to the side because I hate talking with people looking to my back. Had too many people come up behind me. So my background is in safety and quality. My whole career is for instance, called 26 medical specialties to convene in Alabama back in 2000 to create office-based surgery and anesthesia guidelines. And I said, we're here. We can be the 7th in the country to do this. We did it. Still being used and for dental offices, et cetera. I've led quality improvement teams in a bunch of hospitals, been chair at 3 hospitals, done a lot of expert witness work and chart reviews on bad outcomes. And I'm trying hard to not get more involved in all this, but it's really hard for me because, as I said in an interview for the Wood Library Museum, I have a crippling inability to see something that can be improved, especially if it impacts safety and quality, and then just walk away. So at the risk of getting more involved, I'll get involved. several things that have been said raise questions, and I can't even get it all out. But the big thing that I think is missing is already been mentioned. We need a registry. We need closed claims like ASA started back in the 80s. It revolutionized safety. It's why the Institute on Medicine said anesthesiology is the premier medical specialty for safety and quality. It was all rooted in that. We started looking. One team that I led at a hospital threw out the old point and chastise. It was just mentioned. This is on my mind because it was mentioned late. Nobody wants to report. Totally changed the culture of the hospital in a way that we actually had people celebrating coming to the quality and peer review committee for a bad outcome because they found it to be so positive. So what we did is what we're all supposed to be doing in the quality revolution is we made it where it wasn't about you. It's about helping other people not have the same mistake. It's what aviation does. When I was the inaugural chair of the AQI board of directors, the first meeting we had, I said, we're going to create AIRS, the near miss registry. We're going to copy aviation because so many more things come up that you can learn from than a death. We quit presenting at my hospital's deaths that we knew had nothing to do with bad care. It was pretty easy. We reviewed them, and we didn't waste anybody's time discussing them because really it's not required. It's better to spend time on what can we do better and how can we teach everybody to be safer. 2.8 million anesthetics and dental offices. So we need everybody helping. So I think a big problem, it was pointed out, I think 2 years ago at the annual meeting, with a very esteemed expert panel, and I still agree we don't have an accurate numerator and denominator in any state in the country. Why? Because we don't have reporting, and even when things are reported, and even when a state has great regulations, like Florida, they ain't following them. So we did a Freedom of Information request for all the data, and it was amazing. A bunch of bad outcomes, and we looked for the analysis. It wasn't there. And here's a really big one that takes intellectual honesty to accept. But in Texas, for instance, when the legislature reported 80 deaths in dental offices from 2010 to 2015, they took away from the dental board the authority, appointed a blue ribbon panel, but they didn't want anesthesiologist part of it. So having done the quality analysis, so on one of my quality teams, we made it where if we were going to attribute blame or fault to anybody, we, the committee, and I had somebody from every medical specialty in the hospital on the committee, but if we were going to do that, we stopped analyzing, we called in the doctors and nurses involved, and we let them present what happened. Because so many times we went down a rabbit trail that wasn't right because we weren't there. But we peeled back the onion in a very comforting way, and we didn't shame anybody. We never pointed at them and say, you got to do better, because that's been proven to not work. We welcome them to change the culture of safety at the hospital and help their peers not get into this, even if they really screwed up. Okay, you screwed up. God bless you. Everybody worships at your feet. You admitted it, and you're going to help us all learn from your mistake. That's what it's got to be instead of a bunch of dart throwing. I think it's possible to do that, but we all have to come together and agree that we don't want to hide things anymore, because a bunch of stuff's being hidden in every state in the country. And when I've looked at a lot of the bad outcomes in dental offices in the last 5 years, and we don't even agree with one of the more recent ones that methemoglobinemia was the cause. We think it may have been part of it, but I don't think it was the cause. Many physician anesthesiologists don't either. So I would like to help. I'd like to get involved more, but you can't improve anything if you're not measuring it accurately. And ladies and gentlemen, we still aren't measuring it accurately. We're getting together and talking about it and having group therapy, and it's great, and we care, but we've got to help all the people who aren't here understand that they're really not doing it right. Things aren't safe. The dental office is still the wild, wild west when it comes to anesthesia.
Yeah, so thank you for that. That was a great statement. And when I went through the data and the information about reporting requirements, for example, there are still many states that didn't have it. In some states, the timeline is, for example, if you don't die within 2 days, they wouldn't count it as a dental death, even though it was as a result of, something that happened during that anesthetic or sedation. So, like I said before, that's why Sheetal, Dr. Patel's wife, was very adamant that they actually included. But, she very educated lady, very proactive. Not everyone's going to have someone shouting and then going back to their state trying to get them to change things. And, you know, it's absolutely right that we don't have the right numbers. And that's why part of it is just trying to get the right numbers and trying to see. And, you know, to me, one death is one death too many, that none of this should be happening. And people in the community don't understand the difference between going into a dental office with sedation versus a hospital. And so I think it's also important for us to just make sure people understand. There shouldn't be a difference, but right now there is a difference.
You reminded me of another point. I changed the title on a talk that I gave last year, and I'm speaking at a lot of pediatric dental meetings. I'm doing the Greater Dallas Society this coming Thursday. But informed consent is super important. It's unethical to not give informed consent. But most of us aren't giving ethical informed consent when it comes to anesthesia safety in offices. Because if you don't know the numerator and denominator, you can't say how safe it is or isn't. You're giving your anecdotal opinion. Think about that. So I don't know if I connected the dots, but especially on bad outcomes, I think it's very important to have multi practitioner involvement in the analysis. So I'll take it out of the dental realm and tell you that what goes on in small hospitals when it's just a surgeon and a nurse anesthetist is they'll have a bad outcome, but when a surgeon and somebody with potentially 1/8 to 1/10 the training of a physician anesthesiologist, if they're doing quality improvement and assessment of bad outcomes, in a lot of small hospitals they're not. They just get swept under the rug and they go on, right? So if they're doing it, though, and they don't have somebody with the depth and breadth of knowledge that a physician anesthesiologist has, it's just the surgeon and the nurse anesthetist, they can't even get to the root cause of the problem. And if they do, they're probably not going to be pointing a finger at each other because it's such a close, tight-knit community. So we have to avoid that.
Great. Thank you again, Dr. Flegenhoff, for those very relevant points. I think we have a lot of people in this audience who've really committed to trying to get this data outcomes going. We're going to continue to work together. I appreciate the across the aisle and working together with both AMIS and the American Society of Dentist Anesthesiologists. SAMBA works closely with them. We're going to continue to work together and find a way to really capture all this data, whether or not an anesthesiologist is involved, and get those numbers going. It's to the benefit of everyone. I thank everyone again for their time this morning. If there were further questions we didn't get to, please feel free to reach out to any of us. We'd be happy to continue talking. Thank you.